Another very paternalistic idea that if you don't give somebody access to a midwife, that means you're not giving them access to a home birth. Therefore, they will make the wrong choice.
Today, we're chatting with Ola Levitin, a registered midwife here in Ottawa with 15 years of experience. In this episode, we unpack common misconceptions about midwifery care, an often underutilized option for families.
If you're curious about your care provider choices during pregnancy and birth, this conversation is for you.
Thank you for agreeing to chat with us today, especially since you're taking time out of your
Thanks for having me.
holidays. We are so excited to have this conversation and really wanting to highlight that there is multiple care providers available for people who are starting to plan a family or have already become pregnant and are looking for their care provider.
Sure.
So I think there's some myths and miscommunication and misunderstandings about who families can go to for their care during their pregnancy and postpartum period. And we thought, who better to speak to than a care provider who is one of those people for the community? So, Ola, maybe start off by letting listeners know, how long have you been a registered midwife and how did you come into this profession?
Such a loaded question. I've been practicing for 15 years. I had a whole different profession and life before, and really, after my own births and pregnancies, realized that choice in birth is really important. My life's logo is "Peace on Earth begins with birth," and I truly believe that.
I love that.
When we have an opportunity to birth our babies in a safe place where we're heard and understood and respected, that sets us up for a life that's empowered, and I think it's strength that we draw on later on as we grow, like for the rest of our lives. So I think that is a really, really important part. Life,
Mhm.
and that's, a lot of people will I did an interview for midwifery applicants at Ryerson a long time ago, and some people said,
Mm.
I want to be a midwife because I love babies. And I remember thinking,
Mm.
I hadn't even
Oh,
thought about the babies part of
interesting.
it.
Your job, really.
Right, like I really wanted to be a midwife for women, to provide that choice.
Mm.
What's a good birth? A good birth is one where someone feels heard, understood, in control of their decision making, right? And so that no matter what
Yeah.
happens, whether you have a vaginal birth by your fireplace at home, or you have an emergency cesarean, once you process it, you will feel still empowered by it and still feel that you had control over that experience, which I think is really, really, really important. But now that I've been practicing for 15 years, I love the babies. They're like the cherry on top. Once everything else has been done, kind of thing. So that was my motivation
Yeah.
for being a midwife. I worked in Toronto for a couple of years, and then moved to Ottawa in 2013, and have worked at a number of practices in the Ottawa area, but always with have privileges at the Civic Hospital. So that's where I attend the hospital-based births when people choose, and then the Birth and Wellness Center, and of course at home.
Which I feel is pretty fantastic that within a care provider, there is more choice. But if a family is not able to connect and get a midwife, the other two options are obstetrician and family doctors who deliver. Is
Who
that
do
how you
OB?
kind of
Language is
OB?
powerful.
Okay.
So I'm going to get on my
Power,
soapbox and say pizza gets delivered
not
and
babies.
people birth their babies. And that comes from a place of active participation and power. And some people will say, well, if you say a woman delivered her baby, that is also an active term. But if you look historically of what the word delivery meant, it comes through a lot of paternalistic lenses where it came from. So I think that that language is really powerful, and
Really is.
always fall into that term myself because it's still so widely used, but really try to
Used.
consciously use the word birth, whether somebody births their baby or births their placenta, or I catch their baby or attend
Catcher,
their birth,
yes.
versus use the word delivery.
Delivery. It's so funny. My very, very first birth as a brand new spanking doula, it was a home birth. And I arrived and the midwife was already there. And her license plate said, I delivered.
Mm.
And I was like, huh, interesting. But I too agree with you that nobody delivers the baby but the birthing person.
Yeah. And but it's funny, I said to a friend actually, I said, "Oh, I'm a midwife and I have caught about 537 babies and been to over 1,000 births." And she said, "Oh my God, did you drop the rest of them?"
That's so cute. You're like, "Oh, that's hilarious." The term caught makes it sound like they're shooting out of
And
you.
sometimes they do, but
Oh my God, did you drop the rest of them?
Your hands were actively there. Is that what you're describing?
Exactly. But you're absolutely right, Christine. And every
Mm.
province has, different regulations for who can attend births. And in Ontario, particularly, you're right. We have three options. So a registered midwife, an obstetrician, or a family doctor who does OB.
Right.
Mhm.
So the born stats just came
Mhm.
out and I had it written down. Do you remember? So they had the division of percentage of the amount of families that accessed obstetrical care, family OBs, and midwives.
Hmm.
Does anyone remember? Do you
I just
remember?
wrote the
Yeah.
We're going to have
midwifery
to put it
percentage. I think it was about 19%. Um, in the last
19%.
12,
Yeah.
well, over the last 12 years, but in the last couple of years, we've got up to about 19% of,
But I do remember it went from 12% to 19%.
Mm.
And then the family OBs, whatever their percentage was, it went down. And then obstetrical was in the 80s.
mm-hmm.
What
And,
does that mean? That there's a wait
OB.
yeah,
list,
and
right?
a
So that
lot of
means we're
people.
not meeting the demand.
Exactly. And a
Mhm.
lot of people don't even
Yeah.
know that there is a thing called family OB. And they
Mhm.
do a wonderful job of attending births. I feel like their philosophy, can't speak for them, but it appears to me that their philosophy is a little bit between midwifery and obstetrics, where many of them will be smaller groups. They'll have more of the continuity of care piece, so they'll actually still
Hmm.
come for their births. They still have nursing involved, monitoring the labors, but you have a bit of more of a continuity of care with the family docs, and then they'll follow the mums and the babies for the 6 weeks postpartum,
Mhm.
just like midwives do.
Hmm. Just
Yeah.
like midwives too. Yeah. And with obstetrical care, it has the biggest percentage. And can you speak to why the biggest percentage is more for families using OBs versus the family OBs or midwives?
Of course. So,
Mhm.
in the past, it was
Mhm.
midwives that delivered or
Mhm.
caught all the babies, right? And it
Yeah.
was obviously a female-led profession. And in the beginning of the 1900s, patriarchy came in and pretty much took over birth, control over women's bodies, and midwifery
Mhm.
was pushed to the wayside. It became illegal in many places, and so
And still
it's
is
it
Mhm.
still
today.
is, right? But if
Mhm.
you look at countries like Holland, their system is that by default, when you are pregnant, you get a midwife, and
Oh.
then if your pregnancy becomes more complicated, higher risk, you are, transferred
Transferred.
to an OB. So,
Mhm.
so in a system where, and as you know, most births are normal, or they start out as normal pregnancies,
Mhm.
low risk is best followed by midwifery, both
Mhm.
for the women, but also for a healthcare system, right? As far as costs, and
Mhm.
so in reality, we should have a lot more midwives than we have OBs,
Yes.
right? But
Yes.
that's
They're trained surgeons, right? Like that is ultimately what
Hmm.
they are. Yeah. Mhm.
Yeah.
exactly.
And thank goodness we have them
Yes.
for the times that is needed. But
Mhm.
not just Holland, I would also think other parts of the world have a bigger midwifery presence than obstetrical, like the UK and other places in Europe. Is that, yeah.
100%. But if you look at maternal and neonatal mortality and morbidity, the countries that do have midwifery as a very integrated profession, not just for births or pregnancy or postpartum, but for primary care, because there's a whole spectrum, right, of women's health throughout their whole life that can be really supported well by midwifery. And so in countries where that's really well integrated, we do have better outcomes.
Mm. Yeah.
Yeah.
So what does midwifery care if someone's new to it? What does it look like from your perspective and the philosophy behind midwifery? I guess we're speaking obviously to Ontario at this
Yes.
point because
Hmm.
it's different in other places and countries and provinces.
Right.
So,
And it's a really good question. Like, what's the difference, right? Like, when I'm pregnant, what would my care look like differently if I had any one of those three care providers in Ontario? And so, midwives, family OB, and obstetricians will follow the same protocols we have in Ontario. Will offer all the same blood work, all the same ultrasound. Yep,
Testing.
all the same ultrasounds. That's an accepted, protocols in Ontario for following pregnancy, a minimum number of prenatal visits. So we will attend people's births wherever they choose, whether it's hospital, home, or the birth center. We can chat about the birth center later, what it means.
Oh.
And then the differences kind of end up a little bit at this point in the sense that, yes, family OB will continue to take care of mom and baby for those 6 weeks. People will go to their clinics for weight checks, for well mom or baby checks, or people will go see their own family doctor at that point, or a pediatrician if that's what they choose to have for their baby. And with midwifery, we will follow that mom and baby diet for 6 weeks. The first week, we will see people at home, usually on days 2, 4, and 6, kind of every other day for the first week. And then at 2 weeks, 4 weeks, and 6 weeks, people will come to our clinic for those well women checks and baby checks, support with breastfeeding or whatever kind of feeding somebody chooses to do. So lots of support. I always say those are kind of the bare bones visits. And if somebody has struggles breastfeeding, their baby's not gaining weight, we will come back every other day. And there's a lot of value in supporting people in their own home, right? Because I can see what their pillows look like, right? I can see that they're hanging over the edge of the bed when, and I'm like, no, like this is the pillow. This is where your partner needs to help you. And there's
Help
you.
you. Yeah.
Yeah, those for me, like I had midwifery care, and those for me were life saving. Also, just like not leaving the house, not like I think the stress of leaving the house also contributes to a lot of anxiety, and maybe the feeding goes differently than it does right when you're out versus at home. And so, yeah, you being able to see the real deal, and I think there's maybe a better mental health assessment. Like, how does the house generally look? Like, mess is perfect.
Fine.
We love seeing mess. We don't love seeing perfect, pristine
100%.
houses,
Yeah.
but right? But is it functioning well in there too, right? Like, is there enough kind of food supports that way
And there's a
too?
couple of
So,
other things. If somebody has other children, putting their baby in in the car and going to see a care provider, they feel, what, I've breastfed 3 other kids. They've all done well. So really, do I really need to go? I'll go maybe once. But sometimes those are the babies that actually aren't doing well, right? So sometimes you only get the care because the midwife shows up and follows closely. The other piece I feel really, really sad is that there is no check on the mom, right? So if you have an OB, you have that 6-week appointment, but in those 6 weeks, I remember a family friend called me on day 3. They didn't have midwifery, and said, "Hey, we're really worried about our baby, and can you come in? Can you weigh him?" And I came in and did all this stuff, and then I asked her, I said, "And how are you doing?" And she started to cry. No one had asked her. So she'd been to see the pediatrician. Everyone's all about the baby, but no
Maybe
right? No one had taken her blood pressure. No one had checked her fundus. No one had asked her, how are you feeling?
bleeding. Do you have an appetite?
Yeah. Or yeah, what are you crying a lot? Like those, yeah, those early indicators of there could be some anxiety or just what's normal, right?
Exactly.
Versus kind of what's,
Milk and
Yeah.
tears come together, right? There's a huge progesterone crash, right? Unless somebody explains it to you. We read so much about postpartum depression that when your milk comes in and you're bawling because your body's not feeling the same as it did, you're like, oh my gosh, is this postpartum depression? Where am I at with all this? So having that midwife come into your home and reassure you, like you said, and tell you what's normal is just as valuable
Hmm.
as catching something really abnormal.
right?
Oh, for
Absolutely.
sure. For
Yeah.
sure. And midwifery only became legal in Ontario
In
when?
1995.
Wow. Oh my goodness.
Yeah.
Like 70, no,
It's
95?
not that it became legal. So it
Okay.
wasn't illegal.
It was regulated. It was more regulated.
Exactly. So
Right.
before
Okay.
1995, we did have midwives who
Mhm.
were trained in other countries, who were paid privately by people who wanted a
Okay.
home birth. There were no
Right.
midwives in hospitals. There was no regulation about it, but it wasn't illegal. Um,
Okay.
and then in 1995, it became a regulated profession. All the midwives that were already practicing in Ontario got grandfathered in by a credentialing program. And then we had the midwifery education program that was established in Ontario at 3 sites, right? We had Laurentian University, McMaster, and it was called Ryerson at the time in Toronto. Now it's called, TMU. Unfortunately, Laurentian closed a few years ago, which was
Oh,
very
yeah.
sad,
Devastating.
devastating for rural populations, for
Hmm.
indigenous populations, and for the francophone populations especially.
Yeah.
There is a big ask right now happening in hopes to open a francophone midwifery education in Ottawa.
Ooh.
So fingers crossed. If
Mm.
you see any petitions coming across your desk, please sign them.
We have. We have.
Absolutely. Yeah. Yeah,
So
for
one of the
sure.
things I valued too, like so the postpartum, like we can go back to postpartum, but the prenatal. So I had an OB for the first, I can't remember how many weeks. It was quite far in. I would say 28 maybe, and that's usually I think when people risk out of midwifery care. So I was able to get one, but in the meantime, I'd been seeing an OB, and my appointments were literally go pee on the thing. I come in, they're like
Stand on
one
the
foot out the
scale.
door and like they're late always. And I was just like this kind of everything's good. Yeah, everything's good. Okay, great. Bye. Like the normal pregnancy is the normal pregnancy. And then when I switched to midwifery care, they made me sit there for like an hour. I was like, really? I get to sit here and
Going to talk about all of these things, all of
oh
them.
yeah, maybe would you mind walking us through kind of that model of care is so
And
different compared to what
it's
we
not that OBs don't care more. It's just
no,
that
it
their
wasn't that at
volume,
all.
No.
it's
Time.
volume,
Time.
right? So,
Absolutely.
if
Yeah.
you look at the 4,600 births that happened at the Ottawa Hospital, last
Mhm.
year, and the number of births that were done by OBs versus the number of births that midwives, like I think we did like 700 births in all the two practices. So very few. And so every midwife in Ontario takes, let's say, an average of 36 to 40 clients per year. Per
Okay.
year.
Okay.
And so that
Wow.
is why we have such long waiting lists. But also that's what allows us to provide, we call it Cadillac care.
The level of care.
The what care? Sorry, the Cadillac care?
Cadillac care. Yeah.
So you're absolutely right. Our appointments are 30-minute long appointments. I'm still late though on a lot of my appointments.
Oh, yeah, that's okay.
But 30-minute appointments for sure. That's why we can do home visits. If you think about it, home
Mhm.
visits, like some days I might only have, 4 home visits, which is actually a lot. It doesn't sound like very much. But when they are
Yeah.
anywhere from Stittsville to Russell, and each appointment takes a good 45 minutes or sometimes an hour and a half if somebody's really struggling with breastfeeding, that is a full
Mhm.
day. I'll be lucky if I'm home for dinner, right?
For
And
Right.
in
sure.
that day, I might get called to do a labor assessment, right? Like when we're doing that, we are on call. Um,
Hmm.
Mm.
OBs have a lot more clients that they're taking care of, so they have a much faster turnaround in their day. Part of the midwifery program actually is to do a month of following an obstetrician. And so I remember when I did my placement with an amazing doctor in Toronto, he just let me do my thing. And he would see 3 people and I would see 1. Because I just like, I couldn't not say all the things. Like, how could I not say all the things?
That's it. Well, and I also had midwives for my care providers with my children. And I brought up the regulation in the year because I gave birth for the first time in 2000. And when I was telling people that I was going to have a midwife in my care, they were like, "What? Are you? Are you going to have the baby in like the
Mhm.
jungle? Or like, are you having a home birth? What? What? Shouldn't you have a doctor?" I'm like, no. No. But anyway, so going to the appointments, of course, my partner, my husband would come with me. And at one of the appointments, my midwife had me lay on the exam table and palpate my belly. And she's like, "Oh yeah, there's your baby's head," and did the like thing. And she looked at my husband and said, "Want to feel your baby's head?" And he was like, "What?" So she put his hands and then rocked his hand back and forth. And she said, "That's your baby's head." And we left the office and he looked at me and he said, "Why would anybody want anything other than the care of a person like that?" Like for her to involve him and like just, he felt so included. He felt so part of the experience and it made all the difference to him,
Mhm.
you
Yeah.
know?
Yeah, and having the partner at those, like, prenatal visits too is so invaluable as well.
And not
Yeah,
just the
Yeah.
totally.
partner. I think my favorite part
Mhm.
is when I have repeat clients that come back and now they're having their second or their third baby. And
Yeah.
and that first child who I was at their birth, I now get to teach them how to feel where the head is on their, and I can
Yeah.
teach them to push the button.
Include
Doppler,
them.
and have that picture of them
Mhm.
listening to the heart rate of their sibling. It's really special. It is truly a family-centered experience from, you're right, from the pregnancy to birth, where we're actually offering the partners to have their hands on the baby if that's what they want to do. Or
Yeah.
have children present at the birth if that's appropriate
Mhm.
for this family to involve in
Like
postpartum. I have lovely pictures of siblings with my stethoscope and listening.
listening. Yeah, that's a baby. There's so many pieces that midwifery care is different. And I feel like we really also want to touch on a little bit of the misconceptions and differences between midwives and doulas, as Erin and I came from our careers as birth and postpartum doulas. We really want to address that. There's still so many misconceptions that, I say, well, I'm going to have a doula at my birth. I don't need a midwife, or equating them to be the same thing, which they clearly are not. So could you walk our listeners through what your education and what it takes for you to become a registered midwife? My earbuds keep falling out because my ears are very small. If I smile too much, my ears push them out. And then Erin and I will, of course, then let people know what education and training looks like for doulas. And
Mhm.
so let's teach people the differences between the two.
I love that you asked that question because there are, even though midwifery has been regulated since 95, there are so many misconceptions, not just in the public, but actually in the healthcare system itself. I have had people
Mhm.
who have come from, having just their regular family doc that did their first initial pregnancy tests, and now they're trying to decide which care provider to have. And the conversation goes something like, well, if you want a hospital birth with an epidural, you need to have an obstetrician. And if you want to have a home birth, then you can have a midwife. And it's like, no, 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 no. But that's coming from a healthcare provider. And then the same, like you said, I've hear that a lot. Well, I have a midwife. Why do I need or why would I consider having a doula? Or the opposite. I'm just going to
Yes.
have a doula. Why do I need a midwife? So lots of misconceptions, and I love that you asked. So for midwifery, it is so we have a Bachelor of Health Sciences degree. If you're doing it full time, it's a year and a half of coursework and 2.5 years of clinical placements. Part of those placements, like I said, you're doing a month with an L&D nurse, a month with an obstetrician. People do a month in various other interprofessional settings, like I did mine with NICU and then a lactation consultant. Some people will do that interprofessional placement overseas to learn what midwifery looks like
Mm.
elsewhere to add to the richness of their experience. And then the rest of the time, so it's an apprenticeship program in the 2.5 years where you're hands-on, you are in a midwifery clinic, you're following midwives, you're making those relationships with pregnant people going to their births and postpartum, really learning hands-on in the community what it means to be a midwife. So then we graduate and we receive it's an official name, midwife. So nobody else can use the term midwife because it is actually a legal profession. So there are certain restricted acts in our healthcare system that nobody can just do. So for example, putting in an
Mm.
IV, so puncturing somebody's skin, your
Yeah.
fingers in somebody's vagina, those are protected acts and can only be done by registered professions. So I keep my registration active every year. When I retire, I am no longer allowed to call myself a midwife.
Really? Oh, I didn't know
I
that.
might still be. So it is a profession, just like a doctor is, just like a physiotherapist, like a chiropractor, name it. We have a college,
Yep.
College of Ontario of Midwives, who regulates what our scope is, what we're allowed to do, what we're not. The college protects the public, making sure that all the midwives are educated appropriately, registered, continuing education.
Education.
Absolutely. So
Mhm.
every year when we register, we have to show proof that we are up
Huh.
to date on emergency skills, on neonatal resuscitation, and only then are we then granted our registration. And so that's how the public is protected. So if anyone has any complaints, so just like the College of Physicians of
Mhm.
Ontario, we have a College of Midwives in the same way. Um,
Mhm.
so and then doulas for me are very, very valuable as a profession as well. So not a regulated profession as you'll see, but provides incredible physical and emotional support to, for me, the whole family. Um,
Mhm.
in that birthing experience, right? So you have your midwife who's providing clinical care, right? Monitoring blood pressure, making sure the baby is head down, right? In the labor, listening to baby's heartbeat, putting in an IV, setting up an epidural, right? Like depending what this.
Vaginal
Exactly.
exams.
And
Oh.
then the doula is there for the birthing person, hands-on, 100%, focused on that person, advocacy, like I said, physical, emotional support, which is really important. I have people say to me, so I always bring up doulas in prenatal appointments. And so I have people say to me, well, we decided we don't need a doula because we have a midwife. And I really have to explain that the clinical care that I provide, the documentation that I provide, the discussions or the communication with hospital staff, like that all
Mhm.
takes me away from being with you every single contraction. And as you
Mm.
know, right, labor can be really intense and you need someone there
Mhm.
every single contraction. And so I think
Mhm.
doulas are invaluable in
Yeah.
helping people have an amazing experience. So I encourage
Mhm.
doulas for all my clients if they have the resources to have one. Or
To
there
do
are
so.
volunteer doulas organizations in Ottawa as well that support different populations that are really valuable.
Yeah, you're
Absolutely.
not providing that kind of you might they're here or there, but you've got paperwork, right? You're mentioning all the other you're so busy and we want obviously you need to be there for that clinical aspect. So as doulas, being there for that continuity piece and the physical, like you mentioned, and the emotional piece so that you can also do your job
Exactly.
properly, right? And being able to focus on the things you need to. So yeah, I
Mhm.
love working with midwives as a doula. I know Christine did as well. Like that, there was a lot of partnership and yeah,
Yeah.
the same connection of care, right?
Well, I also remember being at a birth at the birth center, and Ola, I think you came in as the second, or you were just like even a temporary. And my client was in the tub, and I was leaning over the tub and squeezing her hips. And then as I was doing that, you were rubbing my back, and I was like,
Ooh,
"This is so
it's
nice."
a new profession, the doula for the doula. Okay. No. Uh,
Yeah,
I
but I
love
have a
that.
question, and I know what the answer is, but I would just like to bring to light. I'm pretty sure that when obstetricians go through their education, do they have to do that kind of rotation like you do? Do they spend a month with midwives?
Not in Ontario. I think in other countries they
Hmm.
do, and I've read some books where
Hmm.
um, people have done that, but not in Ontario.
Hmm.
Yeah, that's unfortunate. I remember, I think for nurses as well, labor and delivery nurses, if they haven't had the chance to attend, because if you have a midwife, you don't get a nurse at the hospital. You don't get a combined care, so they don't always get exposure to how the philosophy of midwifery care can be. My client was having a pretty precipitous last stage of her labor, which moved into the second stage very quickly. And the midwife called in a nurse off the floor, and the baby was born before the second midwife could get there, essentially. And once the birth had happened, I had stepped back, and the nurse was there, and she came back and she stood against the wall and she went, "I had no idea a birth could be like that."
No.
Because the birthing person was kind of in this half squat, and the midwife was behind her and caught the baby quite literally, and then passed the baby through
Mhm.
her legs, and then mom claimed her baby, and then we all just kind of stopped and took a breath, and she was so bewildered and so rocked, but in such a positive way, that I feel like that peace on earth starts with birth really should encompass this greater knowledge of the different levels of care, I think.
Mm.
I'm speaking to the choir here, I know, but
It,
Yeah.
it's what you see, it's what you're trained. So yeah, absolutely. I mean, I will catch a baby in any position really, because it's you learn from being a student, this ability to pivot, right, and meet the birthing person where they're at, and have a lot of confidence in your skills for protecting the perineum to try to avoid a tear, being able to do maneuvers in case the baby is stuck in any way, right? So part of the reasons so many births are on their back with obstetrics in the hospital, because that is what you're taught, right? And so if you're not taught how to even do a vaginal exam when someone's on their hands and knees, everything is a little bit upside down, right? So if you're only ever taught certain maneuvers, that's what your safety zone is, right? And you're feeling you're keeping the patients, as they call them, right? The birthing moms on their back. That's the safest thing you can do for them, because that's how you know how to deliver their babies, right? Versus when you've been taught to catch a baby in the bathtub, or in the shower. You are able to pivot, right? You know that if the baby is stuck, you can move the mom. And so it's wonderful that we can do that we have that training.
Mhm.
it
Yeah,
is, it really is.
know the anatomy very well. Upside down checks
Exactly.
following.
Well, and maybe we can go back to, now you said that your education was a year and a half, the learning in the classes, and then two, so that's 4 years of university. And maybe Erin can speak to the difference between what our training was.
Mm. Our training was a 4-day in person. We did in person. I know there's a lot more virtual now, especially since COVID. So ours was 4 days. And then we had a certain amount of births we had to attend, and readings, and a few papers and shadowing that we had to do. And then pretty much, I mean, after that, then it's up to the doula. They don't even have to get officially certified. Once they've done the training, they can call themselves a doula and start practicing. So a lot of people don't even get quote unquote certified. They just kind of do a bit of the homework and then off they go. So our training is a lot shorter. and we always say like midwifery is like from the waist down and doulas are waist
Mhm.
up kind of thing, right?
Mhm.
So we have nothing to do with any of that clinical pieces. We have an understanding of it and we've studied birth, but not the way you have, right? Really from that emotional information and physical components. So I don't know if I missed anything, Christine. But yeah.
No, it sounds
Yeah.
perfect. Yeah, for
Yeah.
sure. The difference is 4 days and 4 years. So
Right.
how you could possibly put those two professions on the same plane is, and it is due to the lack
Mhm.
of education sometimes, and it's the lack of the information sharing. There's a time where I bravely asked my family doctor, who she's female, and I said, when someone comes to you and says, and then you do the test and you confirm pregnancy, what is your information that
Mm.
she says, well, I refer them to an obstetrician. And I said, oh, well, you don't tell them about the other options in care provider. And her response was, we feed our own.
Hmm. Interesting.
So I was surprised. And I think it wasn't for her lack of knowing what the options were. So that was maybe her preference, maybe her bias, but family doc OBs are her own. And yes, there's less of them, but it should still be offered as an option. I was very surprised by her response. And that was like 8 years ago, 9 years ago. It wasn't like 20 years ago, right? And it still baffles me that there's still so much confusion around the options for families.
You know what? I think there's also a sense that home birth or out of hospital birth is unsafe. And unfortunately, another very paternalistic idea that if you don't give somebody access to a midwife, that means you're not giving them access to a home birth. Therefore, they will make the wrong choice. Right. Just like we know with if you don't have access to abortion, that doesn't mean women don't get abortion. It just means they get unsafe abortions, right? So, and
Correct.
that is the reason why midwifery became regulated in Ontario, right? Um, always tell the story that in 1985, before we were regulated, there was a birth on Toronto Island where a baby was born at home, and unfortunately, the baby died, and there was an inquest. As to what the heck was going on, who were these midwives that were attending this home birth, and our government had to make a decision. Do we make midwifery illegal and therefore stop women from even choosing an out of hospital birth, or do we regulate it and making it safe? And thankfully, just like with
Mhm.
abortion, there was enough wisdom to say that no, the best thing to do is to make it safe, right? Because women will make the choices that they will make. And if you force something to go underground, you are not.
It will go
It will go
underground.
underground, and then you will have untrained care providers. So it felt that women will choose to birth their babies wherever it is, whether it's under a tree at a birth center, at home, or at the hospital. And the best thing we can do is have care providers who are trained in all of those places, so that it's a
Mhm.
safe choice. And so I wonder, with the response that you received, because there is still bias against women birthing not in hospital, there's this very misguided sense of protecting their patient, of not offering them, the choice
An unsafe choice
in
in
their
their
eyes.
eyes.
Exactly.
In
Yep.
their eyes, yes.
Versus we
Yes.
know that an out of hospital birth for women who have a healthy pregnancy, who have a baby that's head down, who are being attended by a care provider trained in and out of hospital birth. I always say this in my info sessions. An obstetrician is amazing at surgery, but you do not
Yes.
want them to have at your home birth because they're not trained to do that. And so
No.
you want to have a midwife who is trained, who has equipment. Our
Mhm.
tax dollars pay for every midwife when we graduate. We get $8,000 in equipment that we buy. We have a level 1 hospital in our car at all times. I often joke there's no room in my car for my children because we bring sterile instruments, oxygen for mom, oxygen for baby, everything. A level 1 hospital means everything that you need for a low risk birth. There's no obstetrician on site, so that if we have a complication, we are moving to hospital for that extra help. And so you have to have all that. I would not want to be a midwife in the US, in the States, where midwifery is not integrated. The equipment, I tried to buy resuscitation equipment in the US because I thought it would be cheaper when I first graduated. I was not allowed to purchase it.
Mm.
Yeah. I had to have a prescription from a doctor. And I said, but I am the doctor. Like, I'm writing my own prescription. I know I'm allowed to use a Doppler. I could not buy it over there, right? So when
Wow.
you're doing a home birth at a home without the equipment you need, without, life-saving drugs, without resuscitation for baby, that is not safe. I 100% agree. That is not a safe place. But in Ontario, where you have 2 trained midwives at every birth, whether it's home birth center or hospital, an out-of-hospital birth is a very, very reasonable option for people.
Yeah, and I think
For
that
low risk, of
the
course.
other misconception, right, is the hospital and the epidural option, right, with a midwife. And I think that's something hopefully people will learn today, is that you have those options here in Ontario, at least. Again, not in Ottawa
Uh-huh.
specifically, not everywhere. But yeah, that can stop people, I think, right? If they're like, but what if I want an epidural? Yes,
Hmm.
support
Yeah.
as well. When is it the moment though that you have to transfer care? So either in the pregnancy or during a birth, for example, when would that moment kind of come?
So, usually only people without pre-existing significant conditions are accepted into midwifery care, right? So you don't have diabetes, you don't have high blood pressure, you're expected to have a low risk pregnancy, a low risk birth, and as we know, in pregnancy, lots of things can come up. So what happens when that happens? As a midwife, I would consult with an obstetrician. Usually they're obstetricians in my hospital who I know and love and trust. I will send them a referral. They will see my client in person. And depending on what's going on, different things may happen. It may be that they provide advice on how to monitor the pregnancy going forward. It may be that it is a transfer of care. For example, if somebody develops diabetes with insulin, they require insulin to keep their blood sugars normal for the rest of their pregnancy. That is out of midwifery scope. They will be transferred to an obstetrician. But as I say to everyone on their first visit, it's very difficult to get a midwife. It's very difficult to lose a midwife once you get one. Because once we have that spot and we have given you that spot, we do not kick people out of care
Lightly.
if they
Yeah.
are transferred to an OB. So
Mm.
if my client is transferred to an OB as the most responsible care provider because they need insulin, for example, for diabetes or high blood pressure medication, I still stay in their care. I am still part of their circle of care. They will still come to see me, not as often because that's just too many appointments, but they will come to see me. We will still chat about what their labor might look like, what are their birth wishes, and I help them understand what that induction might look like, right? What their labor might look like with an obstetrician at the civic hospital. They might still page me in early labor and get advice. So very much still remain in that person's care if they're transferred to obstetrics, and then will attend their birth in what we call supportive care. Usually will come at the time of pushing, at the time of the birth. And once the baby is born, we're there, try to be there for the birth as much as we can. Once the baby is born, usually babies are admitted in hospital under midwifery. So under me, mom might remain under the obstetrician, let's say if her blood pressure is still high. But if there was another reason, for example, if you have a very, very tiny baby on ultrasound and the birth is happening under OB and the baby is born and the baby, lo and behold, is 7.5 pounds, and all was well and mom is well, then the OB says, congratulations, Ola, she's all yours, and off they go. And both mom and baby are admitted under midwifery in hospital. And then regardless of what happens of the birth, we will still follow people for that full 6 weeks postpartum. So they still have our 24/7 availability to pager, prenatally or postpartum. Like I said, we'll still come to their birth. So still very much involved in their care.
Yeah.
Is that the case for every midwifery collective in Ottawa?
Oh, wow.
So if their transfer of care happens, but they still are in your care, how do those other spots? Is it open up kind of spontaneously? Is it babies that deliver early or, that kind of thing? Like how do those magical spots open up
So
sometimes?
sometimes people will move away. That's like the number
Okay.
one way that magical last minute spot
Oh,
will
okay.
show up.
Yeah.
So one thing that midwifery can do, so the way midwives get paid, we are paid by our healthcare system. A lot of times people say, here are all these things that we do and go, and how much will this cost me? And I go, no, it's free. It's still part of our healthcare system, right? But we do get paid from a different pocket of money from the Ministry of Health, not through OHIP. Right. So physician, right.
Okay.
So midwifery is paid by the same pocket of money that pays community health centers. And so we are able to take care of uninsured people. Right. So newcomers
Right.
to Ontario or to Ottawa who are waiting for their permanent resident statuses to be established. They're residents of Ontario, but they have not received their OHIP status yet, or they're students who have lost their university insurance because pregnancy isn't covered, find themselves in this uninsured state and have to pay for care. There's a whole reason, there's a whole population of people that are uninsured. We're not talking about visitors that just come to Canada to give birth.
Have their baby.
There's a lot of misconceptions about that. That's what that means to be uninsured. It actually is not. And so midwives are in a unique place where I get paid the exact same salary, whether I take care of someone who doesn't have OHIP or whether it's someone that does. And as you can imagine, newcomers who don't understand our system, who don't have the resources to pay tons of money for obstetrics, are really well served by midwifery, right? On a social level, on a clinical level. And so we try to leave some spots. I know in our clinic we do. Personally, I do. I try to leave some spots in my practice for what we call late into care clients. Right. I've had people walk off a plane at 35 weeks pregnant, and the immigration worker calls me and says, this Ukrainian woman just came. Can you please take her? And because I leave those last minute spots, I'm able to support people. And so sometimes those late into cares don't come at the last minute, right? So then I reach out to the community and go, but I do have a spot. Happy to take whoever wants it.
Oh, wow.
Yeah. I had a client switch care at like 37 weeks once, just because the midwifery model was something she really wanted. And I think people do have misconceptions that it can still happen. Just because if you tried to get a midwife early in your pregnancy and you were put on the wait list, don't give up hope. It could still happen.
Yep, exactly. And if you are on the waiting list, and you're getting to that third trimester, it's still worth emailing the practice and saying, hey, you know what? I know I'm just a couple of months from giving birth, but I would still like to switch to a midwife, because when we do have those spots that have been kept and now we're trying to fill, we might reach out, but having somebody reach out and say, I'm still interested is really helpful.
Mhm.
Oh,
Hmm.
so nice.
Well, maybe we wrap up with a hot button question. How would you like to see the future of midwifery? What would be the most important change for you in the next decade?
Midwives everywhere. I really think the way the system is, too many details to go into in this forum, but we really should have midwives at every point of women's lives because we're really well positioned. As you know, we have a primary care crisis. We don't have enough family
Mhm.
doctors. It's not just about catching babies. Midwifery is really suited to be serving our population and families in so many different ways, and that is my hope that we can have postpartum clinics where a midwife runs those well baby checks and those childhood vaccinations, right? And also checks on mom in those 6 weeks, right? For all those people that don't have a midwife in their pregnancy and birth should be able to
At least for the postpartum.
postpartum pap tests, right? It doesn't even have to be in that 6 weeks, birth and 6 weeks piece of their lives, right? Like you can have midwives everywhere. We have excellent clinical skills that are completely being underused in our healthcare system.
I agree. I agree. All right. Well, we'll build the postpartum house for you to come and
Yeah.
take care of all the postpartum.
I love it. That's perfect.
Thank you so much, Ola. I think we're gonna have like part C, part D. We're gonna have to chat with you again and explore some other pieces.
Sounds good.
Yeah, so
I
much.
look forward to it.